Domestic violence is a serious problem in the United States. It often affects every segment of society. Whether you are a victim of domestic violence, someone accused of domestic violence, or a witness to what you suspect is domestic violence, there are many things for you to know about this subject. So let's define domestic violence. Domestic violence, which is sometimes also referred to as intimate partner violence, refers to the victimization of an individual with whom the abuser has or has had an intimate or romantic relationship. According to the Florida Department of Children and Families, domestic violence is a pattern of abusive behaviors that adults use to maintain power and control over their intimate partners or former partners. People who abuse their partners use a variety of tactics to coerce, intimidate, threaten, and frighten their victims. Domestic violence may also include physical violence, sexual violence, emotional abuse, isolation, economic abuse, pet abuse, threats relating to children, and a variety of other behaviors meant to increase fear, intimidation, and power over the victim. Furthermore, domestic violence knows no boundaries. It occurs in intimate relationships, regardless of race, religion, culture, or socioeconomic status. The CDC defines IPV as violence or aggression that occurs in a romantic relationship. Because of the similar nature of the definitions, this course will use the terms domestic violence and IPV interchangeably. The next 9 slides will cover national and state statistics and legislation about domestic violence. Domestic violence is one of the most serious public health problems in the United States. More than 36.4% of women and 33.6% of men have a lifetime history of IPV. In Florida, the weighted lifetime prevalence of IPV, including rape, physical violence, and/or stalking, is 37.4% among women and 29.3% among men. Although many of these incidents are relatively minor and consist of pushing, grabbing, shoving, slapping, and hitting, IPV resulted in approximately 1,500 deaths in the United States in 2019, with 214 of those deaths occurring in Florida in the same year. Statistics indicate a slightly higher rate in 2020, with 221 deaths in Florida in 2020. One of these difficulties in addressing the problem is that abuse is prevalent in all demographics, regardless of age, ethnicity, race, religious denomination, education, or socioeconomic status. In response to troubling domestic violence statistics, Governor Childs appointed a task force on domestic violence on September 28, 1993, to investigate the problems associated with domestic violence in Florida and to compile recommendations as how the problems should be approached and ultimately resolved. As a result of this report, Florida enacted legislation during the 1995 session implementing those various suggestions of the task force. Specifically, the legislature amended Section 455.222 of the Florida statutes to require that all physicians, nurses, and other healthcare providers take a 1-hour continuing education course on domestic violence every renewal cycle. In 1997, at the request of the governor's task force, a work group was established by the Florida Department of Law Enforcement, or FDLE, to evaluate the feasibility of tracking incidents of domestic violence in the state. This resulted in the creation of the Domestic Violence Data Resource Center, or DVDRC. The original mission of the DVDRC was to collect information related to domestic violence and to report and maintain the information in a statewide tracking system. In 2000, the creation of Florida Statute 741.316 required the FDLE to annually publish a report based on the data gathered by the fatality review teams. As part of Governor Jeb Bush's initiative, the Family Protection Act was signed into law in 2001. The act requires a 5-day mandatory jail term for any crime of domestic battery in which the perpetrator deliberately injures the victim. The law also makes a second battery crime a felony offense, treating offenders as serious criminals. In 2007, the Domestic Violence Leave Act was signed into law by Governor Charlie Crist. This law requires employers with 50 or more employees to provide guaranteed leave for domestic violence issues. Healthcare professionals are in a critical position to identify domestic violence victims in a variety of clinical practice settings. Nurses are often the first healthcare provider a victim of domestic violence will encounter in a healthcare setting and should therefore be prepared to provide care and support for these victims. Although women are most often the victims, domestic violence extends to others in the household as well. For example, Domestic violence includes abused men, children abused by their parents, or parents abused by their children, elder abuse, and abuse among siblings. Many victims of abuse sustain injuries that lead them to present to hospital emergency departments. Research has found that 49.6% of women seen in the ER reported a history of abuse, and 44% of women who were ultimately killed by their abuser had sought help in the ER in the 2 years prior to their death. These alarming statistics demonstrate that healthcare professionals who work in acute care, such as hospital ER, should maintain a high index of suspicion for battering of the patients that they see. Healthcare professionals who work in these settings should work with hospital administrators to establish and institute assessment mechanisms to accurately detect these victims. For every victim of abuse, there is also a perpetrator. Like their victims, perpetrators of domestic violence come from all socioeconomic backgrounds, races, religions, and walks of life. Accordingly, healthcare professionals should likewise be aware that seemingly supportive family members may, in fact, be the abusers. Victims of domestic violence include female or male intimate domestic partners, pregnant women, children, elderly, and same-sex couples. So this slide talks about the characteristics of a domestic violence victims. They may fear their partner's temper. They may want to avoid conflicts and disagreements at any cost. More than likely, they display poor self-esteem and poor self-image. They could also complain about headaches, nausea, and other stress-related symptoms. They may want to spend all their free time with their partner, avoid friends, and even end relationships to avoid anyone from finding out about the abuse. They may also have some physical injuries such as black eyes and bruises, and that they may take the blame for the abuse. Abuser characteristics have been studied far less frequently than victim characteristics. Some studies suggest a correlation between the occurrence of abuse and the consumption of alcohol. A man who abuses alcohol is also likely to abuse his partner. Other studies demonstrate that abusive partners are generally possessive and jealous. Another characteristic related to the abuser's dependency and jealousy is extreme suspiciousness. This characteristic may be so extreme as to border on paranoia. Domestic violence victims frequently report that abusers are extremely controlling of the everyday activities of the family. This domination is generally all-encompassing and often includes maintaining complete control of finances and activities of the victim. In addition, abusers often suffer from low self-esteem, and their sense of self and identity is directly connected to their partner. Extreme dependence is common in both abusers and those being abused. Due to low self-esteem and self-worth, Emotional dependence often occurs in both partners, but even more so in the abuser. Emotional dependence in the victim stems from both physical and psychological abuse, which results in a negative self-image and lack of self-worth. Financial dependence is also a very common, as the abuser often withholds or controls financial resources to maintain over the victim. So what makes the relationship vulnerable to domestic violence? The conflict and fights between marital partners. It could be the instability of marriage, such as divorce or separations. Maybe one partner exerting dominance and control in the relationship over the other partner. It could also be economic stress or unhealthy family relationships and interactions. Communication patterns of couples who resort to interpersonal violence contribute to the friction of these relationships. Both partners may have failed to learn effective problem-solving skills. Abusers may not have learned anger management strategies in childhood. Studies show that couples who have engaged in interpersonal violence tend to communicate more negatively than non-violent couples. They may also not focus on a way to end the argument, rather communicate with anger or hostility. Similarly, they tend to not notice positive actions exhibited by their partners. Remember that couples do not need to be married for domestic violence to occur. Studies conducted in both the United States and Latin America show that victims who were living with their partner had a greater chance of being abused than did those who were married. So what are community influences associated with increased rates of abuse? It could be poverty and crowded living situations, the lack of access to social groups where different values might be learned and practiced. Another one could be little community response when domestic violence is witnessed. What psychosocial factors contribute to domestic violence? Shifting socioeconomic status may influence rates of abuse. More women are working outside the home, making them less financially dependent on their partners. However, not all women have learned the skills needed to support themselves outside the home. Victims and abusers may have been exposed to parental violence. They may not question these behaviors. Additionally, these individuals may have failed to learn effective problem-solving and/or anger management strategies in childhood. Some cultures actually tolerate male violence against women. Different models have been developed to demonstrate what happens within an abusive relationship. During a clinical assessment, a potential victim may not feel safe enough to share that she or he is at risk. As a healthcare team member, you might observe some of the behaviors described in these models. Two different models are often used to portray the patterns of behavior seen between domestic abuse perpetrators and their victims. These models include the cycle of violence and the Duluth model. The first model we're going to look into is the cycle of violence. Tension building phase. Problems may start when the perpetrator blames the victim for a problem. The perpetrator may slap the victim, and the victim may offer to fix the situation or accept the blame, even though she had nothing to do with what had happened. This is to prevent the perpetrator from blowing up. Tension may continue to build with intermittent episodes of the perpetrator making more accusations, engaging in verbal abuse, or using other intimidating behaviors. The victim may respond by walking on eggshells so as to not further agitate the perpetrator. This is actually the longest phase. Tension and anger mount, leading to an explosion or an act of aggression. Explosion or battering phase. Once the perpetrator's anger reaches a peak, the victim may be exposed to either physical, sexual, emotional, verbal, or financial abuse. This is where the actual abuse happens. During this phase, the victim often blames herself or himself. Honeymoon phase. In the honeymoon phase, the abuser is apologetic and may promise to never do it again. The victim is often blamed at this point. So, for instance, if you could keep this house cleaned up, this thing would have not happened. It's your fault. The perpetrator may even deny the event, saying something like, "That wasn't really bad," or "I didn't want to do that." At this point, the victim sees abuser as a loving partner. The cycle then begins again with a period of calmness before the next incident. So you wonder what keeps the cycle going. Basically, there are three dynamics that serve to maintain the cycle. First is love, second is hope, and lastly fear. So love. The feelings of love for her partner may be important to the victim. The victim learns to focus on the good part of the relationship. Hope is when she remembers that the relationship didn't start out that way and holds on hope that things may change. Lastly, fear. At some point, the victim begins to fear that threats of worsening violence or death may turn out to be a reality. The fear associated with leaving and being found by the abuser, then suffering severe consequences, helps to keep the victim locked into the cycle of violence. Developed by the Domestic Abuse Intervention Project, the Duluth model provides more examples of behaviors abusers use to exert power and control over victims. So using isolation by limiting her movement, controlling her every move, the way she talks, the way she walks, and so on and so forth. Using emotional abuse by humiliating her and making her feel guilty. Using intimidation, such as showing off weapons or by smashing things around. Using coercion and threats, making threats of physical harm. Using economic abuse by denying access to finances or basically just giving her an allowance. Minimizing, denying, and blaming. Making light of the cause, saying that it was you or her partner that caused it. Using children. They would take their children away or use their children to make them feel guilty. And then another one is using male privilege by treating her like a servant. So why do women stay? Most women do not stay in an abusive relationships. But for those who stay, they may be afraid for their safety. They may have limited knowledge of what resources are available, such as legal assistance and shelters. Some of them may also have strong religious or moral beliefs about marriage or divorce. Some fear that by leaving, their children will suffer, and many, if not most of those abused have been cut off from their family and friends and have inadequate emotional support when making this decision. Additionally, lack of finances when they decide to leave. Often they have and don't have employable skills and work experience necessary to sustain them and their children once they leave. Intimate partner violence can lead to both long-term and short-term consequences. Long-term exposure to stress of IPV violence has been associated with both physical and mental health problems. Physical problems may include headaches, back pain, seizures, and some GI issues. Mental health problems may include depression, increased substance use, and/or dependence, maybe deliberately harming themselves, and suicide. There is no universal guideline for identifying and responding to domestic violence, but it is universally accepted that a plan for screening, assessing, and referring patients of suspected abuse should be in place at every healthcare facility. In 2013, the U.S. Preventative Services Task Force found evidence to support a recommendation that clinicians screen all women of childbearing age for IPV and refer those who screen positive for intervention and/or counseling. The key to an initial assessment is to obtain an adequate history. Establishing that a patient's injuries are secondary to abuse is the first task. Clearly, there will be times when a victim is injured so severely that treatment of these injuries becomes the first priority. After such treatment is rendered, however, it is important that healthcare professionals not ignore the reasons that brought the victim to the emergency department. Assessment should be conducted routinely whether there is a presence or absence of indicators of abuse. It should be conducted orally as part of the face-to-face healthcare encounter. It may include both written or computer-based healthcare questionnaires. Assessment should be direct and non-judgmental, using language that is culturally, linguistically appropriate. Assessment should be conducted in private, meaning there's no friends, relatives, or caregivers present. It should also be confidential. Prior to inquiry, patients should be informed of any reporting requirements or other limits to provider-patient confidentiality. Assessment should be assisted, if needed, by interpreters who have been trained to ask about abuse and who do not know the patient or the patient's partner, caregiver, friends, or family socially. So how often do we check for history of domestic violence or IPV? We do it during each new admission assessment, when the patient returns for a follow-up visit with a new health concern, when a patient reports a new intimate partner as part of the routine health history, and when there are signs and symptoms to raise concerns, or at other times at the healthcare team member's discretion. So when do we not ask about IPV or domestic violence? One, if the staff cannot secure a private space in which to ask questions. Maybe if there are concerns that assessing the patient isn't safe for either the patient or staff, or if a staff member is unable to secure an appropriate interpreter. If a staff member is not able to ask about domestic violence or IPV, the provider will place a note in the chart stating that screening was not completed and a follow-up appointment may be made. Posters, safety cards, and patient education materials about domestic violence or IPV may be made available in exam or waiting rooms, bathrooms, or on your discharge instructions. Assessment of domestic violence victims should occur immediately after disclosure of abuse and at any follow-up appointments. Assessing immediate safety is priority. Having a list of questions readily available and well practiced can help alleviate the uncertainty of how to begin the assessment. So the following bullets are some of the examples, the questions that you would want to ask the victim. If you are caring for the person in a healthcare setting, the primary goal is to remove the victim from the situation. You may need to treat any injuries and making sure that you're documenting it carefully. You also need to help the victim identify herself as a battered woman. You may also need to assist her in identifying her support systems. Maybe inform her of the referral sources such as shelters, counseling therapy resources, and any legal resources available. You also want to help her assess the extent of danger by asking some questions like, are there guns in the house? Is there any history of homicide or suicide attempts or fantasies? And so on. If the victim chooses to return home, make sure she creates a personal safety plan that includes keeping copies of important legal documents ready at a friend's house or in a safe place at home that can be easily accessed. Also have a plan to stay safe in the home, including an escape route. So there's a detailed plan available at this link, Personal Safety Plan. You could click on the link and note other important planning steps that will help your potential victims exit safely. To determine present and past history of abuse, you want to interview the patient privately. You're going to be using both direct and indirect questions to determine if abuse is present. Example of indirect question would be, how are things going at home? Or how does your partner treat you? Direct questions would be, what are your fights like at home? Do fights ever become physical? And then there's this link below that you may want to click on, and it's more interview tips from the Stanford University School of Medicine. The Department of Health and Human Services reviewed current domestic violence screening and found that screening remains low across healthcare settings, although recommendations are in place. Clinical staff were found to be more likely to provide regular screening if they had received training in how to screen patients, they were female, and they were younger, and that they were nurses rather than physicians. To help individuals who have identified an alternative sexual orientation, you want to provide a private location for assessment away from partners. Also, ask about intimate partner violence. In addition, you want to confirm if they want other individuals to be told about their sexual orientation status before sharing this information with others. Lastly, refer individuals to another caretaker if you are unable to interact with them respectfully. There is an established system in the United States to respond to reports of child abuse and neglect. However, this has not always been the case. This is not because child abuse, neglect, and maltreatment are new social phenomena. Rather, the terms child abuse, child neglect, and child maltreatment are relatively new, despite the fact that this social problem has existed for thousands of years. The World Health Organization estimates that nearly 53,000 children are murdered each year. The prevalence of forced sexual intercourse and other forms of sexual violence involving touch among boys and girls under 18 is 73 million and 150 million respectively. The United States Department of Health and Human Services reports that around 678,000 victims of child abuse and neglect nationally. The victim rate is 9.2 victims per 1,000 children in the population. Children in their first year of life have the highest victimization rate at 26.7 per 1,000 children of the same age in the national population. The victimization rate for girls is 9.6 per 1,000 girls in the population, which is higher than the boys at 8.7 per 1,000 boys. American Indian or Alaska Native children have the highest rate of victimization at 15.2 per 1,000 children in the population of the same race or ethnicity. African American children have the second highest rate at 14.0 per 1,000 children of the same race or ethnicity. The youngest children are the most vulnerable to maltreatment, with 46.6% of child fatalities younger than 1 year old and died at a rate of 22.77 per 100,000 children in the population of the same age. Boys have higher child fatality rate than girls at 2.87 per 100,000 boys in the population, compared with 2.19 per 100,000 girls. Perpetrator is the person who is responsible for the abuse or neglect of a child. 50 states have reported 518,136 perpetrators. More than 4/5 or 83.4% of perpetrators were between the ages of 18 and 44 years. More than 1/2 or 53.7% of perpetrators were women, and 45.3% of perpetrators were men, and 1% were of unknown sex. 40.3% of victims were maltreated by a mother, while 21.7% of victims were maltreated by a father. 13.4% of victims were maltreated by a known perpetrator who was not the child's parent. The truth is we may not know about the child's abuse. Child abuse is the most underreported form of abuse, as children are often too traumatized and afraid to talk about it, and there is rarely anyone in the household to advocate for them. Children may tell another child what is happening, but they do not share their experiences with another adult. Generally speaking, child abuse and neglect can be defined as any act or series of acts of commission or omission by a parent, caregiver, or another person in a custodial role that results in harm, potential for harm, or threat of harm to a child under the age of 18. In more than a dozen states, human trafficking of minors is included in the definition of abuse. Physical abuse is generally defined as any non-accidental physical injury to the child and can include striking, kicking, burning, or biting the child, or any action that results in a physical impairment of the child. Non-accidental injury to a child by their caregiver can result in skeletal injury, burns, bruising, and central nervous system injury from head trauma. It is important to determine if an injury was inflicted rather than accidental when a child is seen in a healthcare facility. Of the children who experience maltreatment or abuse, 17.2% suffered physical abuse. Some children suffered all three maltreatments: physical, sexual, and emotional abuse. A parent of the child victim was the perpetrator in 78.1% of substantiated cases of a child maltreatment. Abusive head trauma is the leading cause of child abuse deaths in the United States. The U.S. government estimates that about 30 children younger than 1 year of age per 100,000 are injured from abusive head trauma, resulting in at least 80 deaths each year. So who should report abuse? In the state of Florida, everyone is mandated to report child abuse. It is immediately important to protect children from physical, emotional, and sexual abuse and neglect. Unfortunately for the child, the damage does not end there. The long-term consequences can include being removed from their parents and placement in the foster care system, along with a host of physical and psychological long-term problems. Follow-up treatment and care are essential to reduce the severity of these consequences. So who needs to report what types of abuse? Reasonable cause for suspicion is based upon behaviors that have been observed or reported that cause the professional to believe that a specific circumstance might involve child abuse or neglect. Reporting suspected cases should be done in good faith, and mandatory reporting laws give the reporter immunity from criminal and civil liability, regardless of the substantiation of abuse. However, if mandated reporters fail to report an incident of a suspected child abuse or maltreatment, they may be charged with a Class A misdemeanor, subject to criminal penalties, and can be sued for monetary damages for any harm in a civil court. It is vital to remember that mandated reporters are not required to provide absolute evidence. This is the responsibility of Child Protective Services. Research presented by the Centers for Disease Control and Prevention suggests that elder abuse is a common and serious problem affecting an alarming portion of the older population living in America. Research presented by the CDC also suggests that the prevalence of elder abuse may be on the rise due to the ever-growing older adult population. As a result, healthcare professionals should be familiar with elder abuse. Elder abuse possesses the potential to dramatically impact an older adult's health, overall well-being, and quality of life. Therefore, it is essential that healthcare professionals possess insight into elder abuse as well as effectively identifying those patients that may be victims of elder abuse. Elder abuse may refer to an intentional act or failure to act that causes or creates a risk of harm to an older adult. Healthcare professionals should note that elder abuse may refer to a single act, a repeated act, and/or a lack of appropriate action. Healthcare professionals should also note that elder abuse typically occurs within relationships where there is an expectation of trust. Financial exploitation or abuse may refer to the illegal, unauthorized, or improper use of individuals' money, benefits, belongings, property, and/or assets. Examples of financial exploitation include misuse of an individual's funds, denying an access to his or her own funds, taking money under false pretenses, using an individual's credit card for personal use without consent, fraud, embezzlement, identity theft, forgery, forced property transfers, as well as the improper use of power of attorney. Healthcare professionals should note that financial exploitation or abuse may be inflicted on an older adult by a member of his or her family, as well as friends, personal acquaintances, and outside sources, such as telephone and internet scams. So what are the steps that can be taken to decrease elder abuse? The DHHS Task Force Executive Roadmap provided 5 goals for all individuals who work with the elderly. We need to increase public awareness of elder abuse, investigate on how cognitive capacity and mental health issues affect both the victim and the perpetrator, improve support and training for paid and unpaid caregivers, assess on what elder abuse costs victims and perpetrators, and identify financial factors which contribute to abuse, and invest more resources in service, education, and research. So where can you get help for victims and perpetrators of domestic violence? Use non-judgmental approach to discuss the situation with patient. Ask their permission to help them seek safer situation. If victim is in acute danger, be sure to involve the law enforcement. Healthcare professionals often are the first to see signs and symptoms of abuse and neglect. Their observations are crucial in substantiating that abuse and/or neglect has been occurring. They are in a key position to help because of the trust and respect that patients often have for their healthcare providers. The last 6 slides are basically contact information on where to report abuse. Also included are information for advocacy, intervention, and shelter information.